Hi, my name's Tori and I wish I knew more about blood products.
Hi, my name's Letitia. I wish I knew more about taking care of myself when starting shift work.
Hi, my name is Lydia. I wish I would know more about how to work as in a team and solve conflict.
Hello, welcome to Five Things, the nursing podcast from the Royal Brisbane and Women's Hospital. My name is Liz Crow.
I'm Jesse Spur, and this is a podcast by, for, and with the amazing nurses and health professionals in our corner of the world. We hope to connect with a global community as we move from surviving to thriving. Welcome to Five Things.
Hello, my name is Liz Crow.
And I'm Jesse Spur.
Welcome to another episode of Five Things, and today we are welcoming Bec Russo, who is a nurse practitioner candidate for kidney replacement therapies, and she is here to talk to us about haemodialysis. Welcome, Bec.
Hello, thanks for having me.
Very pleased to have you. We'd love to hear a little of your nursing origin story and how that's woven its way to being a nurse practitioner candidate in kidney replacement therapy.
So I really have spent my entire career nearly in renal. I landed into it as a grad in 2005 and really never left, and have been really privileged to work across sort of every sort of facet of renal medicine, from pre-dialysis, transplantation, and then doing home dialysis therapies. And I love clinical work. So when the candidacy arose, I thought that's absolutely for me. It's like fulfilling my dream of becoming a nephrology NP.
Yeah, how wonderful.
That's a short and punchy origin story, but without too many twists and turns along the way. So that's really good. That's 80 episodes in. Happy to be surprised by
short and sweet, just like me.
All right. Are you happy to get straight into it?
Yeah, definitely.
All right. So your number one is, what is haemodialysis?
So haemodialysis is doing the work of the kidneys, essentially, using an artificial kidney in the form of a dialyzer that's used during the treatment itself. And it is removing excess fluid from the body that builds up, and it balances the biochemistry out. So when people think of renal and dialysis, they often think of things like potassium. So it's balancing out the chemistry in the blood. Bone and mineral imbalances in the form of calcium and phosphate are corrected. And then those waste products that build up, which are the urea and the creatinine. And these are the ones where patients develop most symptoms from, the urea that builds up. So that brain fog, some nausea, feeling unwell, losing their appetite. So dialysis is really effective and efficient at removing those uremic toxins that build up. It is intermittent though. So they come in for treatment. They usually have about sort of 4 or 5 hours of dialysis. It's really efficient in balancing out the biochemical abnormalities and removing those toxins and removing that additional fluid. Then they have a day off and they all kind of just build up in the blood again, and then come back the next day, and the process is repeated. As I said before, people are usually on 4 to 5 hours, about 3 days a week.
So 4 to 5 hours, 3 times a week. Like, how do people work or function their lives around that? Like, once you go into haemodialysis, is it possible to hold down a job?
People certainly do. I think, and that's just a really, really good question, because it does mean that like 3 days out of their week, their day basically is gone by the time they have dialysis and they get there and then they go home. So I'll talk about this later, but certainly for younger people, we certainly encourage them, if it's possible, to dialyse at home. And for people who aren't suitable to dialyse at home for medical reasons, or they just can't for personal reasons, we try and have some flexibility as much as you can, I guess, within the constraints of the sort of capacity within the system, to offer them sort of shifts that will allow them to work. But it certainly does impact, them from a financial point of view, their independence. So yeah, it can have a significant impact for some people.
So would most hospitals have a haemodialysis like ward, unit, outpatients? Like, do we have that here? How many chairs or beds is it?
Yeah, so at the Royal Brisbane, we have quite a large, we call it a chronic haemodialysis unit. So for people that are established on ongoing dialysis and they come in for 3 days a week, we have an acute unit. So for patients who are inpatients at the time, that may or may not be related to their kidney disease. And then they will dialyse there as an inpatient and go back to the ward. We also will dialyse patients that we call it an out for just for the sake of semantics, whereby one of the hemo nurses will go and dialyse someone in CCU or one of the wards. And then patients who are in intensive care unit can have continuous haemodialysis where they might be attached to it for sort of days at a time. And it's just very slow, more gentle form of dialysis. And lastly, then for people who are sort of stable enough that they don't need that sort of more intense supervision in a tertiary setting, can dialyse in the community. So we call them satellite dialysis units. And the aim of those really is, to keep them within the community, to stop them having to travel sometimes as far as Barbie Island just to come all the way into the Royal Brisbane for treatment. So for people that are stable enough from a medical point of view, they will dialyse somewhere closer to home.
Okay.
I think it'd be really interesting to just get it like a macro visual picture of dialysis, of what that looks like, the machine, kind of the process, like a circuit map, if you will.
Yeah. No, definitely, because even just thinking about getting a visual, it is very strange, I think, just to see what exactly is going on. So in order to dialyse someone, we need to access their blood. So heme refers to blood, so we're accessing their vascular system directly. And I'll talk about access after, but for the purpose of just explaining the process, blood is taken away from the patient via a cannula that accesses their fistula, or the line gets attached straight to their central venous dialysis catheter. It comes out through the blood circuit and gets pumped through the machine to something called a dialyzer. And I mentioned that earlier. It's essentially, we refer it for the patients in a simplistic form as an artificial kidney. So it's packed full of hollow fibres. Blood enters the dialyzer. The special fluid that where all the magic happens enters the dialyzer in the other direction, and it pulls those toxins and other waste products. They literally just go down into the drain, essentially like passing urine. It goes down the drain, and then the clean blood gets delivered through the bloodlines, pumped through the machine circuit back to the patient. And that process basically just continues the entire time. The machine has pressure detecting devices just to make sure that pressures at the access are safe. Their blood pressure is monitored very closely throughout the treatment, because you can imagine if they have about sort of 300 mils of blood outside of their body just doing the dialysis treatment, then some people might need 3 or 4 litres or more of additional fluid removed. So that requires a fairly robust heart, and not all of our patients have, a robust cardiovascular system. So they require really close monitoring just to prevent sort of drops in blood pressure. So basically all the magic happens in the dialyzer, just pulling, just basic diffusion. Things move from a high concentration to a low concentration. So at the beginning of dialysis, all of those uremic toxins, so the urea and the creatinine, are really elevated. The special fluid that enters the dialyzer at the same time as the blood doesn't have anything in there. So they remove really, really quickly. And then there's prescription, which we base on their blood tests, so we can balance things like sodium, potassium, and their bicarb, is individualised, and that's all corrected just in that using the dialysate, the fluid that gets delivered to the dialyzer.
Kind of just like remixing and changing the ingredients in a soup so it tastes better again at the end, isn't it?
Essentially.
Grossly simplifying it. And one thing I guess for new players is we don't call the waste fluid we call it effluent.
We do. We call it dialysis effluent. And I think also people are quite surprised at the volume of water dialysis actually uses. So most of the dialysate, which is that special concentration of fluid that gets delivered to the artificial kidney or dialyzer, is actually water. And it's specially treated. We've got a reverse osmosis unit at the top of this hospital that gets rid of all the chlorine out of the water, because if chlorine comes into contact with red blood cells, they can break down and people can get really sick and require blood transfusions. So most of that is actually water. And we recycle it, thankfully. Yeah.
So your number 2 is acute versus chronic hemodialysis. And you've sort of touched on this, but take us deep dive us into it. What does that mean?
So acute hemodialysis usually is just a short-term requirement. So someone might have established kidney disease already, and for whatever reason, their kidneys have taken an assault and they've sort of temporarily shut down. And medical therapy isn't achieving enough for them. The recovery isn't happening quick enough, and they might require temporary dialysis just to remove those uremic toxins, any additional fluid that needs removing, and particularly if sort of potassium is an issue as well. Generally, if a patient sort of kidney function hasn't sort of kicked in or returned to their baseline, or something that isn't requiring long-term dialysis, that will happen in about 6 weeks. If they don't have recovery, generally they'd have to continue. But acute, as the name suggests, is usually short-term, versus a chronic dialysis where they are sort of requiring long-term dialysis because their kidney function is permanently sort of less than 10%. And they require long-term dialysis as a life-sustaining therapy.
And how bad do things have to get before you go on dialysis?
So that's a really good question, actually, because I think a lot of people think about numbers, and it's really interesting for people who don't work in renal, and they might see a creatinine of 600 or 700 and a GFR of 9 and think, oh my gosh. But provided the patient is clinically well, potassium isn't becoming sort of a problematic, and we can address it with medicines and dietary modifications, that they aren't sort of chronically overloaded to the point where it's really significant for them and it's having a quality of life impact. We can normally just keep managing them in an outpatient setting, just with regular review, clinical assessment, and then regular blood tests. But generally, once that functions somewhere between about 7 to 10%, and those things aren't happening, so the potassium's not being adequately controlled, they're chronically overloaded and it's having a quality of life impact, or those uremic toxins are having such a symptom burden on them that we start dialysis, or another medical reason, they've got cardiovascular side effects, for example. But otherwise, we just can manage them really effectively in an outpatient setting for quite some time.
Yeah, and in ICU, I'd add a really common trigger is severe acidosis, so acid-base imbalance in that critical illness.
Yep, absolutely. And again, then once we patients start hemodialysis, because dialysis corrects that so effectively with the sodium bicarbonate on the machine, then they can stop taking things like Sodibic. But they might have to start taking other things like phosphate binders, because we swap one for another, but yeah.
All right. Your number 3 is vascular access and hemodialysis. Why is this important?
So their fistula, we often refer to that as the patient's lifeline, because it is their access to having hemodialysis. So I guess for a little bit of background, what is a fistula?
I was just about to ask that because I don't actually know.
So the cannula size that we use to perform hemo is a 17 gauge at a minimum. So it's far too big a gauge to cannulate just a peripheral vein. So if patients are being followed up with known CKD, we try and sort of access plan early. Once their GFR hits about 20%, we have sort of MDT education and planning for sort of what modality is best going to suit them. So if they choose hemodialysis, we plan for an AV fistula. So that involves mapping their veins. So the preference is their non-dominant arm, just for ease for them. To find a suitable artery in a vein, then it is a surgical procedure by a vascular surgeon to join the artery to the vein. So what you then have is an arterialized vein because arteries have such a higher capacity, they have more blood flow through them. They join that. Once that's joined to the vein, it thickens the vessel wall up. It grows it essentially. And we rest it for at least 6 weeks just to make sure that it's maturing nicely. They have an ultrasound just to check the health of it. And then hopefully after that, then we can start accessing it for dialysis. In terms of preserving the fistula, we can't highlight the importance of that enough because not having that can be completely detrimental to a patient. That could be their last access. There's a greater infection risk, using a permacath. So our preference is to avoid that if possible.
So what's a permacath?
So it is, I think that's actually just the brand name. So it's a central venous access device specifically for haemodialysis. So it's a double lumen, centrally inserted catheter that sits in the IJ, external jugular vein, and is used it accesses blood in the same way, just in a different place. So it normally will sit at their sort of upper left or right chest, and will remain in there usually as temporary access. Maybe we're waiting for their fistula to mature or be ready for use, or they've had a surgical revision. And unfortunately, some people just don't have suitable vessels to form a fistula. So their permacath, or the central venous access for dialysis, is their only access. But if either a CVAD or permacath or a fistula, it's accessed by haemodialysis staff only, and really useful, I think, for people who are on the ward who might not be on hemo yet but are access planning. It's a good idea even just to ask them, are we saving one of your arms? Do we need to avoid doing blood pressures or venesection on them? And for people who do have fistulas, the main point is avoiding those things as well, but just not occluding them in the first place. So we just don't want to have tight wristbands or bracelets on their fistula arm. Definitely no blood pressures, venesection. You can feel the fistula if you're looking after a patient, and at that anastomosis, so pardon me, that surgical join, it's like a bzzz, we call it a thrill, but it's that turbulence, that blood coming together. So if you
you can feel it.
Yeah, and the patients are asked to check it twice a day themselves. So if you have a patient that you're caring for and you have a concern, think that it's not buzzing as strong as it was yesterday, feel empowered to escalate that. That's so important. No one's going to be mad at that. They would rather know that maybe that we've identified a problem with it. So yeah, feel free the patients won't mind.
Perfect. So if I went to ICU tomorrow because I got sepsis and I'm really, really sick and I need hemodialysis, does a vascular surgeon still have to come and do that, or do they access it differently?
So in that case, it would be a radiologically inserted sort of even more temporary access, which is a vascath. So it's the shorter they just sort of sit. You see the patients that will have them just sitting out of their neck really with a double lumen. Yeah. So that's just a radiologically inserted.
I didn't think we had vascular surgeons coming into the ICU regularly. So it's kind of a different process because of the length of stay that, that they'll have something, an implement in them in order to be dialyzed. Okay. So can I ask, it sounds quite invasive to your veins. You've already mentioned, if we're looking at this as a long-term solution, that to be very careful not to take blood pressures on that arm, to really look after the veins in that arm. Can it become a real issue? Can people run out of vascular access?
Oh, absolutely. And I think prevention is always better than cure. And I think patients come in 3 days a week. We're in a very privileged position as healthcare professionals to be assessing and monitoring the health of that access very, very regularly. So in terms of hemo, it's 2 needles every session. So if you think about whether it's traumatizing that vein very often, so we use techniques to make sure that we're not sort of cannulating around the same spot every time, because it might be easier, but that's not helping sort of that vessel wall. It's just chronically traumatizing that area. And we do regular access assessments to assess the health of it. So just your general physical assessment. We have devices that can measure the flow through the access. And then part of the dialysis treatment itself involves some pressure monitoring. So they can be really useful in determining, well, hang on, something's changed for this patient. If we suspect there might be a narrowing somewhere, there can be physical signs and also signs sort of with some consistent changes on the machine. So it's about sort of regular monitoring. We engage the vascular team really early and do an ultrasound and get them referred in to get them into outpatients to try and address it as soon as we can.
This might be a dumb question, but wouldn't be the first time I've asked a dumb question on this podcast. If I am on dialysis and I've really got to look after, that access, can you go to the gym? Can you, like how much do you have to kind of shelter, protect?
Yeah, absolutely. And certainly when the access is first formed, it's, I guess, just resting it as much as possible. The main thing is really just not occluding it. So, avoiding carrying bags. Lifting weights, it's still possible. We certainly wouldn't recommend doing like 50 or 100 kilo dead weights, things like that. I think it's just, I guess, if you can protect it, you can go swimming with it. It's not like having a pick or like a CVAD when it stops that. A lot of people don't like the way it looks. So from a cosmetic point of view, which is fine. And sometimes people preference another type of dialysis, which is not in the remit of today, but because
it's sticking out, like is it?
Yeah.
So I've seen lots of porta cats, but I don't think I've ever really.
They can develop pseudoaneurysms and get quite lumpy, and then some people just don't want to be cannulated twice a session, 3 days a week.
Yeah.
So that might
Yeah, if you're needle phobic, this would not be a good thing for you.
No, absolutely. So I guess like anything, there's always a risk of infection. So we do what we can to mitigate that. They can develop thrombosis. They can get narrowing.
So are you on blood thinners then if you are on, like if you have chronic kidney, if you're on hemodialysis?
Yeah, so a lot of patients are on aspirin. But then I guess for what other comorbidities as well, they might be on warfarin or apixaban or things like that as well. Some people might need sort of regular ongoing ballooning, for example, or stenting. So they might even have that booked in sort of however so often just to maintain the health of that. So as long as they have their lifeline, it's our responsibility, not just in hemo, but anywhere that the patients present within the healthcare system, just to be aware of their vascular access and how we can preserve it.
So your number 4 is you can do hemodialysis at home. And, that seems crazy. You've just mentioned this big machine and vascular access. So do people literally just hook themselves up and away they go?
Essentially, yes.
Wow.
But it is such a big undertaking. And I think patients who do this at home are so incredible because it is a huge undertaking because they have to learn how to self-cannulate. They have to learn to do essentially what nurses or dialysis technicians in other facilities do in terms of delivering hemodialysis treatment. The training program is done at our unit at Stafford, and they come 3 days a week and have their treatment as usual. But as part of that, then they're learning to self-cannulate. They're learning to line the machines, manage things like what do you do if your blood pressure drops during dialysis. So it's pretty intense training, and some people can take maybe 6 weeks. Some people take 3 to 6 months. It's all individualized, to the patient. But what it means for them once they're home, and that they get established and they're much more comfortable with managing their treatment is it affords them that flexibility of being able to work, have that flexibility around, I have to dialyse, but I'm not sort of working within the confines of a shift time coming into a unit. They can travel a little bit easier. It is tricky on hemo because you have to plan pretty far in advance. But certainly the added benefit of being able to sort of self-care for your treatment is makes it a little bit easier for them. And I think it's just a lot of patients just talk about that self-empowerment and having some control back, because having to do dialysis just impacts really every aspect of your life. We see them for a very short time and they've got a big life outside of coming here. So what that actually means to not have to come into hospital 3 days a week or another satellite unit, I think it's really incredible. I talked about earlier having to have the water. So there's modifications that they need at home. So they manage their sort of portable water treatment unit as well. So it's not only the dialysis treatment itself, they then have to maintain that too. They have to test their water every single treatment to make sure that there's no chlorine, for example. So we don't want them to become unwell. I learned a lot about electricity and water. I tell you what, when I used to do home hemo, we see them at home sort of every 1 to 3 months, and we've got an incredible multidisciplinary team. So we've got access to social workers and dietitians, just really to support them at home. Yeah.
It's incredible. My next door neighbours, for the first or nearly 10 years we lived in our current place, the gentleman there was on home dialysis, and they had all sorts of modifications required, including increasing the mains pressure of the water, because our water pressure in Scarborough is terrible. And so it wasn't pressurised enough to drive the water filtration unit. They obviously had to install uninterrupted power supply, but that gave he was home dialysing for 15 years. Oh,
it's amazing, and we're lucky because most of our patients, I think all of them now, are in the metropolitan area, but they do hemodialysis out in rural and remote as well, and I think they have to be very clever and creative with how that's administered. But I think even from a healthcare access and equity point of view, I think it's incredible if we can provide it, if it suits the patient.
I think that leads us beautifully into our number 5, which is the importance of the multidisciplinary team, the goals of care, and also the family's role, and supports with this, because this sounds hugely invasive in someone's life and life-altering.
Oh, absolutely. And I think when patients start dialysis, they are at a point where they might be incredibly well, or they don't have other complications. And unfortunately, just by being on hemodialysis increases your risk of cardiovascular disease. We have patients on dialysis, and not having sort of multi-morbidity is the exception these days. We have an older, frailer population, and I think, we know that there's an abundance and more than enough evidence to say that having a multidisciplinary team for any chronic disease management is really the gold standard. And I think as some of our patients are on dialysis, if not 2 to 3 years, but we can have patients in our program for a decade or more, the need for that involvement increases. And I think the times have changed. Even when I first started in renal as a baby nurse, I was very idealistic about things and what I could achieve, and what it actually meant to be on dialysis. And it's really just about involving the patient as the number one in the healthcare team to really provide patient-centered care and talk about, well, what are we achieving for you? How are you feeling when you're not on dialysis? Can you work? Can you go outside and socialize? You know, are we meeting your needs from a quality of life point of view? So making sure that we're sort of balancing the treatment itself and making sure that, yep, the bloods look good, dialysis is adequate from that perspective. But is that translating to you actually feeling well and sort of doing what you want to do with, you know, life and work or travel, and making sure that we are offering them referrals to allied health and engaging the allied health team is so important. And I think patients really appreciate that, just in terms of addressing things from a holistic perspective. Otherwise, I just don't think we really could deliver, you know, holistic goal concordant care for our patients.
Because it's a temporizing measure, isn't it? Like that can sometimes get lost with these sort of bridging therapies, that if you're not moving towards transplant, this is forever for that person's ever, potentially, unless it's a reversible kidney. But in the chronic situation, we're temporizing, and if it gets to a point, you're just temporizing to get to the next treatment, which I've definitely seen people at that point, as we see them in their last days in ICU. And you kind of hear them talking and going, probably the last 3 to 5 years sometimes has just been getting from treatment to treatment.
Exactly. And I think it's important to acknowledge, like, without hemodialysis 3 days a week, the person is going to die from kidney failure. So it's so important to check in to make sure that dialysis is still achieving something for that individual, and particularly if they're not pursuing transplantation personally, or whether they're not able to have one from a medical point of view. We know that just over the course of their dialysis journey over a number of years, it's likely that they're going to develop some cardiovascular disease. Their vessels aren't going to be as healthy. Doing dialysis needs more modifications and alterations in order to just get them through a treatment. We need to make sure that we are providing care that is meeting their needs from sort of a quality of life point of view. And so we're addressing that, you know, their emotional health, their spiritual health, and just making sure that dialysis is actually still achieving something for them.
So I'm going to try and summarize that in a very simple way. Number 1, what is hemodialysis? And basically it's a machine doing the job of the kidneys. It's removing the excess fluids, it's balancing the chemistry in your blood, and the main thing is getting rid of those waste toxins of urea and creatinine. Number 2, acute versus chronic hemodialysis. So there are people who require hemodialysis either because they're incredibly ill with something and they might be in ICU. There are some people who might just need hemodialysis short-term with their kidney illness versus the chronic hemodialysis. And this is where approximately after 6 weeks, there's no recovery and people have entered into a chronic long-term situation where they require dialysis. And I think you said the function of the kidney is only at about 7 to 10%.
Yeah. So generally people that are on chronic hemodialysis are followed up for a number of years and their CKD has been managed and they've just slowly progressed to end stage. Yeah.
And they've got poor blood chemistry that just simply can't be cleared by their own kidneys.
They become more unwell, they're chronically overloaded, or there's another reason that there's a medical indication from a cardiovascular point of view, for example, that we actually need to start now.
Perfect. Number 3 is vascular access for hemodialysis. And I guess you said that fistula becomes their lifeline. And so this access is extremely important that you looked after. You spoke about, how that's mapped and how that's put in and what needs to happen. But I think the big take home for me, for our bedside nurses, is that if someone has a vascular access for dialysis, you really need to look after it. No blood pressure cuffs, nothing tight on that. it's really important to preserve because that is that person's lifeline. And your number 4 is that you can do hemodialysis at home. And I guess the take home about this is that this is really hard. It requires lots of training. Not everyone will be eligible or capable of doing this at home. That it requires modifications of the home around water, around constant electricity. But if it can be achieved, it obviously provides a much better quality of life for the person and their families, and you're more able to be engaged in life and travel and work.
Yeah, there's more opportunities and you get water and electricity rebates too. So should have mentioned that.
And last but not least, the importance of the multidisciplinary team and goals for the patient who's on hemodialysis. So to remember that it is a team sport, that it requires a strong allied health, multidisciplinary involvement around, you mentioned dietetics, social work, physio. I'm sure everybody is involved, and that it's important to constantly check in on what are the goals of care for the person who is on dialysis.
Absolutely.
Perfect. I think that's a wonderful wrap. Thank you so much, Bec, for joining us on 5 Things.
Thank you for having me.
The Royal Brisbane and Women's Hospital 5 Things Nursing podcast acknowledges the Turrbal and Yagara as the First Nations owners of the lands we now tread. We pay respect to their elders, laws, customs and creation spirits. We recognise that these lands have always been places of healing, teaching and learning. We also wish to acknowledge the First Nations people of the lands of our global community and encourage our listeners to seek out, listen and learn from the knowledge held in your shared space. As well as all major podcast outlets, you can find us at 5thingsnursing.podbean.com. Please also subscribe and give us a rating on your listening platform of choice. This helps others find the podcast. And finally, if you'd like to connect with Liz or myself on Twitter, we can be found at LizCrow2, and for me, it's inject_orange. We would absolutely love to hear your thoughts, ideas, or feedback. Thanks for listening to 5 Things.